and welcome to Module 1, What is First Aid? So whether you're at home or in the workplace, first aid is essential in order to give somebody that chance of survival by providing some basic life support skills. So first aid is that initial treatment that you're going to give to somebody that's become injured or unwell in the workplace before further assistance arrives. So with the skills you're going to learn on this course, along with some common sense, you'll be able to apply them and be able to help somebody if they've become injured or unwell. So as a first aider, we're going to look at three main priorities. So we're looking at preserving life, preventing the injuries from getting any worse, and promoting recovery. So to preserve life, that may be stemming the bleed until further medical assistance arrives. It may be doing CPR, cardiopulmonary resuscitation, until the ambulance and defib arrives. To prevent an injury from getting any worse, that might be a case of placing somebody that's in shock, lying down and raising their legs, or maybe someone that just feels a little bit unwell, a little bit dizzy, and actually just sitting them down before they fall down. Same with a bleed. If they're bleeding, we're going to prevent it from getting any worse by applying a bandage and putting some pressure and elevating that wound. To promote recovery, so if they're with us, then we may promote recovery by giving them something sugary to drink, for instance, if they had felt a little bit dizzy, a little bit dehydrated, and hadn't had anything to eat or drink that day. It may also be the treatment that they get in hospital to promote that recovery, but we will make sure that we recognise that and call an ambulance as quickly as possible in order to get them the treatment that they need. What we're going to talk about now is legislation. So in the workplace, you may have some responsibilities as a first aider, especially if you're in a supervisory or management role. So in that case, along with the help of your employer, you need to be aware of the Health and Safety at Work Act 1974. So this puts a responsibility on all employers, employees, contractors and self-employed to make sure they do everything so far as reasonably practical to keep people safe in the workplace. So if you're needing to help assist in the workplace by doing this, you need to make sure that you understand your responsibilities there. There are regulations that will filter off the Health and Safety at Work Act 1974, such as the Management of Health and Safety in the Workplace 1999, and that just makes it a little bit more explicit on how employers can comply with the law, so with the Health and Safety at Work Act 1974. That will also give you a lot of detail on risk assessments as well. And one of the first things you'll do, perhaps as a new business or for a new activity, is actually consider the first aid risk assessment management in your workplace. So that brings us on to your First Aid at Work Health and Safety 1981 regulation, which will help you understand exactly what you need to do in order to comply with this law and regulations. So the kind of provisions you need to be thinking about is how many members of staff that you have in the workplace, and then also who else is coming into your workplace. So do you have customers that are coming in? The other thing you need to think about is the type of activities that are happening in your workplace, and also the space, how large the workspace is. Is it across multiple floors? Is it a very large building? So will that make a difference to how many first aid kits you might need or how many first aiders you might need? All this information can be found on the HSE government website, and there's lots of documentations and all the regulations on there to find out further information on how you can comply at your workplace. So as explained earlier, in the Health and Safety at Work Act 1974, it does put a responsibility on the employer to make sure that they're doing everything they can to keep people safe in the workplace. So that would include recording any accidents or near misses, so that they can take a look at those, have a look if there's any trends and make improvements so that we can reduce the amount of accidents that are happening. It may be a case that actually a piece of equipment or activity needs to stop happening so that these accidents don't continue. So the type of information that you might need when filling in an accident form would be the name of the casualty, the date that they had the accident and the time, and the location. You'd need to have a description of what they have injured and where on the body they have injured, and what treatment you gave and any advice you may have given them. You also need to make a note of what happened to them after the incident. So after you've treated them, have they gone home to rest? Have they gone back to work? Or have they actually had to go to an ambulance, or has an ambulance had to come and pick them up to take them to hospital? If a casualty has gone to hospital, so a member of the public that has visited your building, you've had to call an ambulance or they've gone directly to hospital, and it's not just a precaution, that would also mean that a RIDDOR form would need to be filled in. So RIDDOR is reporting of injuries, diseases and dangerous occurrence regulations. Now this is a form that is reported to the HSE, so your Health and Safety Executive, for anything serious. So if somebody was to lose consciousness, to stop breathing, any serious breaks, then that would be RIDDOR reportable, and also any other serious incidences in the workplace. So in order to fill out a RIDDOR form, you would need to have a clearly written accident report form. Now each workplace is different. That may be a paper form for your accident, or it may be an electronic, and that may go to a central hub where a health and safety team will do that for you. Otherwise, usually in-house management will usually do a RIDDOR form. So just remember, once you've filled in an accident form, these will hold people's personal details. So these need to be kept in line with the UK's GDPR regulations. So basically this means that they need to be kept secure so that no one else can have access to them. So under your Health and Safety at Work First Aid Provisions 1981, as we said, it requires you to think about lots of things with regards to your first aid provisions, and one of those would be what you will have as a first aid kit. So there is a standard recommendation as a first aid kit, which I'm just going to show you now. So you would have triangular bandages in there. You'd have a couple of different size bandages for wounds and bleeding. You'd have some plasters in there. You would have a guidance card just showing you some basic information on first aid. You will have some gloves, an eye bandage, and there may be some other bits and pieces in there as well, but they are the main standard kit. When you carry out your first aid risk assessment, you may find that you will need more than the standard first aid kit, and that might be based on incidents, accidents that have happened previously. It may be the activities that are happening in the building that may make you think that you need some different types of kit. So some examples of those would be ice packs. So for example, if you work in the leisure industry where there's lots of sports happening, then there might be lots of muscle and ligament damages that might require some ice packs. You may have some eye wash in there. If someone has anything in their eye, then you can use some eye wash. You may also have some antiseptic wipes. So ideally we'd use water if we have it available, but it's not always that easy. And sometimes these are really convenient to take to a casualty if they can't get themselves to somewhere where you have fresh water. You may also have some scissors in there, as well as some microporous tape for covering wounds, along with some gauzes as well. Okay, so we're going to talk about your responsibilities as a first aider. Now this might be before a first aid incident happens, so around prevention, during a first aid incident and after a first aid incident as well. As a first aider, you need to be able to take charge. You need to be able to keep calm, assess the situation and act as calmly as possible. Have a look around and see if you've got any bystanders that can help you. So they could assist you with calling the ambulance or any other emergency services. They could get you a first aid kit, they could get you an AED and just be there for some moral support. When you arrive at the scene, you need to be thinking about your environment and any dangers that are around. Of course, you are important, you're the most important person. So if there's any danger to yourself at all, then that might mean that you actually can't help the situation other than perhaps calling emergency services. There's no use you getting injured because then they're going to have 2 casualties to deal with. Okay, so consider if they're in water, if there's any traffic around, is there any crowd management that you need to deal with that's going to hinder your approach to this casualty? Also, if there's any objects around the casualty, maybe they've spilt or dropped a glass bottle, maybe there's just general objects in the way that's going to prevent you from actually kneeling down around the casualty and giving them some support. So you've assessed the area and you've determined that it is safe for you to approach and help the casualty. You want to try and get as much information as possible about what's happened and the extent of anybody's injuries. When you approach a casualty, you need to make sure that they will consent to you helping them. So if it is a conscious casualty, you need to explain who you are and that you are a trained first aider and what you would like to do to enable to help them once you've assessed their injuries, if they allow you to do so. If you're dealing with a vulnerable casualty, such as a child, then you would need to try and get the parent or legal guardian's permission to treat that child. If they're not there, then we would assume implied consent. So we would carry out first aid, ideally with somebody there with us, so we're not alone with the child or vulnerable person, as long as they are happy for us to do so and it's not going to distress them further. If you have an unconscious casualty, we would presume that consent has been given and treat accordingly in order to potentially save their lives. When dealing with casualties, communication is really important. We need to make sure that we are calm and confident in what we're doing. We need to make sure that we don't use terms that they're not going to understand, as they may be overly confused because of the condition or injury that they have. We need to be conscious about body language when we're dealing with casualties to make sure that we do look confident and also don't look like we're looming over somebody, especially for a child. So we need to be conscious about that. We also need to be honest about their condition, but also finding that right line so that we don't distress them further if they've got any serious injuries. Another responsibility as a first aider is contacting emergency services. So the kind of information they're going to need to know is your location. So do make sure that you know your full address at your workplace, and that if they are using a sat-nav to reach you, that does actually get them to your address. And if it doesn't, that you know some landmarks in order to direct them so that they can reach you without any delay. They will also need to know how many casualties you have and what type of incident it is, and the extent of their injuries as well. They will also ask you to repeat the location. So we spoke about prioritising first aid treatment a couple of times now, so we're going to go into that in a little bit more detail. So if you've got a casualty that isn't breathing, that is going to come right at the top of our list. If we have someone that has a severe bleed, that will come next. And if we have anyone that has a bone injury, so perhaps a broken bone, or a burn, then that would come next, and then any other medical conditions. So to prioritise, it's breathing, over bleeding, over bones and burns, then any other medical conditions or injuries. During the treatment of first aid, you must make sure that you are conscious of cross-contamination and infection control. So when you're treating somebody, make sure that you wash your hands and you put on your gloves. Make sure that you don't touch the wound or cough or sneeze over the wound. And once you have used any dressings and anything to clean the wound up with, then make sure that goes in a biohazard bag into a biohazardous bin. You may have some cleaning kits that you can use, and they're great to clean up body fluids, and they provide you with a little biohazard bag, which is usually yellow or orange, and then you can pop that in the correct bin as well. In this section, we're going to talk about primary survey. And the primary survey is something that we're going to do when we arrive at the scene in order to assess for anything life-threatening and see the extent of somebody's injuries. So when we arrive at a scene, we've already said that we need to make sure that we are safe. So the first thing we're going to do is we're going to look for any danger. There's actually an acronym that is quite helpful to remember these primary survey steps, which is DOCTOR ABC. So D is for danger. So when we arrive, we're going to assess the scene and make sure it's safe to approach the casualty. So is there any gas, glass, fire, wire, or anything else that could be any danger to you? When we approach the casualty, we will see if they are alert and if they're sitting up, if they're talking to us, maybe if they're asking us for help. So we're going to look at different scales of response levels now. So we're now on R for response. So are they alert? Like we said, did they respond to us? If they're not alert, we're going to move down to the next scale, which is, do they respond to any voice prompts? So, hello, can you hear me? Can you open your eyes? And I'm going to do that by talking into the casualties, both of their ears, in case they're hard of hearing in one ear. So, hello, can you hear me? Can you open your eyes? you may ask them to squeeze your hand as well to see if you have any response there. If that doesn't work, what I'm going to do is place my hands on their shoulders and give them a little shake to see if they respond to that. If they don't, at that point we would deem them unresponsive. And you want to make sure that you've got some help at this point. If there's no one around, just give a quick shout for help. And now what we want to establish is if they're breathing normally. First, before we do that, we need to make sure that there's nothing in the casualty's mouth, because what we're now going to do is open the airway. Okay, so we've done danger, we've done response, and we're now on to A for airway. So check the airway, make sure there's no vomit. If there is, we can turn the casualty away from us or place them into a recovery position in order to clear that vomit out. And then what we want to do is open the airway. So we're going to put one hand on the forehead and 2 fingers underneath the chin and do a head tilt chin lift in order to open the airway. So by doing that, we may have already preserved their life. So by them relaxing, if they're unresponsive, all their muscles could relax and the tongue could block off the airway. By doing this, this has taken the tongue off the back of the throat and potentially enable them to be able to breathe. So now we're on to B, so that's breathing, so we're going to check for breathing. So how we're going to check for breathing is we're going to look, we're going to listen, and we're going to feel. So we're going to look for normal breathing by looking down the chest. We're going to feel for normal breathing on our cheek, and we're going to listen for normal breathing. And we're going to do that for 10 seconds. We're going to say that this casualty is breathing normally. So we then move on to our C, which would be either CPR or circulation. In this case, this casualty doesn't need CPR. So what I would do is, with regards to circulation, just make sure there's no severe blood loss that's appearing. So I haven't noticed any pooling of blood or any damp clothing that could indicate that there is a bleed under their clothing. So that's your primary survey, your doctor ABC, danger, response, check and open the airway, check for breathing, and check the circulation or start CPR if your casualty isn't breathing. So our casualty was breathing normally but was unresponsive. So we need to make sure that they stay safe and that they can maintain an open airway. In this position, that might not be possible for this casualty. So the best position to put them in is what we call the recovery position. So the recovery position will maintain their open airway as they're on their side. So if the tongue won't be able to relax on the back of the casualty's throat, and if they are sick, they will not choke on it. I'm now going to demonstrate your primary survey into recovery position. So I've come into this room and I have found somebody on the floor that appears to be unresponsive. So first thing I'm going to do is I'm going to check for danger. So I'm going to make sure there's nothing around that's going to injure me or further injure my casualty. So I've checked for danger and it's safe to approach. I'm now going to check for response. Hello, can you hear me? Can you open your eyes? Can you squeeze my hand? There's no response. I'm now going to just make sure that the airway's clear, and I'm going to do a head tilt chin lift in order to open the airway. I'm now going to check for breathing. Okay, the casualty's breathing normally. I can't see any signs of any injuries, and I cannot see any medic bracelets that might indicate that he has a medical condition, and there's no severe bleeds. But I am concerned because he has been unresponsive for a good couple of minutes. So I'm going to shout for some help, and I'm going to ask somebody to get me an ambulance and a first aid kit. So I want to place the casualty in the recovery position so that they can maintain an open airway, especially if it's myself that needs to go and call the ambulance and get the first aid kit if I was on my own, for example. So I know I can leave him and the tongue isn't going to relax on the back of the throat, or he's not going to be sick, and that's going to compromise the airway. So the recovery position, the arm closest to you, you're going to move just up out of the way, anywhere that it will naturally go, because basically we're going to bring them towards us and we don't want them to squash their arm. I'm now going to get the hand furthest away from me, and I'm going to link fingers, and I'm going to put his hand on his cheek here. If the casualty is wearing any big rings, I would just turn them around so it doesn't dig into their cheek. And I'm going to keep my hand here at all times throughout the turn. From the outside of the leg, the furthest leg away, I'm going to lift up at the knee and get the foot as close to the bottom as possible. I'm now going to use this as my lever. So it shouldn't matter what size I am or what size the casualty is, I should be able to turn them if I'm using this method. So push down as hard as you need to on the leg. And just bring that foot off that leg there. Bring the shoulder over. And most importantly, make sure that the casualty's airway is open. So just make sure the chin isn't right against the chest. You can open the mouth and just make sure that airway is open. You can now check the back from this point as well to make sure there's no injuries. To continue to check for their breathing, we can put our hand in front of their face and feel for the breath on our hand. And we can also see the rise and fall of the chest on the front and back here as well. Some other things to consider during the recovery position is if the casualty has anything in their pockets, because if you're rolling them onto a side where they've got lots of keys or phone, that might be quite uncomfortable, so you might need to think about rolling them onto the other side. Also, if they're wearing glasses, you may want to consider taking those off, because that can also be quite uncomfortable for them. It doesn't matter what side you roll your casualty on, unless there's any injuries to consider, and usually that would be injured side down. However, if you have a heavily pregnant lady that is required to be placed in the recovery position, then you should roll her onto her left side to make sure that we don't cut off any blood supply to baby or mum. So for the primary assessment that I just showed you, you did see some elements of a secondary assessment being done. So I looked for any medic bracelets and I looked for any visible signs of any injuries. When I was checking for breathing, looking for or sensing any smells, so any smell of any alcohol or any fruit smelling, sweet smelling smell that may indicate that they had high blood sugar levels. Now, on a conscious casualty, a secondary assessment can be quite a bit easier, because obviously they can talk to you and they can guide you through their signs and symptoms and any history that might be relevant. So a secondary assessment does consist of history, signs and symptoms. So the history might be, do they have any allergies that are relevant to what's going on today? Are they on any medication? Do they have any past medical history that might be relevant? When was the last time they ate or drank anything? And of course, what you would ask probably first off is what's actually just happened. And if you can't get that information from a casualty, you might be able to get that from a person that's just a witness to the situation, or perhaps a family member. So for your secondary assessment, that's your history. So then your signs and symptoms. So signs is something that you can see. So whether that's that they look very pale, that they're sweating, that they look flushed in appearance. And the symptoms would be something that they could tell you. So do they feel sick? Can they feel pain anywhere in particular? And that can all help you determine how to treat somebody. I'm now going to take you through your respiratory system. So the respiratory system is primarily made up of your airways and your lungs. So our body is able to breathe spontaneously as long as we have air to breathe and our airways are open. In order for us to be able to breathe, our diaphragm contracts and flattens, our ribs are elevated, leaving room for the air to be drawn in. When we exhale, everything relaxes and the process starts again. I'm now going to take you through CPR and AED. So if a casualty has collapsed and stopped breathing, we're going to need to carry out cardiopulmonary resuscitation. If the brain is starved of oxygen for any longer than 3 minutes, that can cause serious brain damage. So we need to act as quickly as possible. What we would do is we would start by carrying out our primary survey. So we would check for danger, we would check for response. Hello, can you hear me? Can you open your eyes? There's no response. going to check the airway, open the airway, and check for breathing. Okay, so I have an adult casualty that's not breathing. If I had help at this point, I would ask them to go and call an ambulance and bring back an AED. If I was on my own, I would have to leave the casualty at this point and go and get an ambulance and an AED and then come back and commence CPR. So, I've checked for breathing, they're not breathing normally, and I have an ambulance and a defib on its way. So what I need to do is I need to start giving chest compressions. So basically, if a casualty has collapsed suddenly, so in a cardiac arrest, they would have been breathing okay, and then they would have collapsed because their heart would have stopped pumping blood around the body. So we need to try and do that for it as quickly as possible. So that's why we concentrate on the compressions first for an adult casualty. So we're going to place the palm of our hand on the centre of the chest, right on the breastbone. Our other hand is going to come over, lock fingers. I'm going to get a little bit closer to the casualty with my knees here, and I'm going to bring my body above the casualty as well and keep my arms nice and straight. Now, to do compressions, you need to aim for about 5 to 6 centimetres depth on the chest, which is about a width of a credit card. And the speed is going to be between 100 to 120 compressions per minute, which is about 2 per second. So, I've done that 30 times. So you're going to do 30 compressions in a cycle, making sure that when you are coming up on the chest, that you are fully releasing without coming off. So the recoil is just as important, so we can allow that heart to fill up and then the blood to fully flow through the body. After 30 times, we're going to go straight to give rescue breaths. Now, if there's any reason you didn't want to give rescue breaths, so if there's any blood around the mouth or any vomit, then you don't have to give rescue breaths. If a pocket mask arrives, so a face shield, you could use one of those at a time that was appropriate. So to give rescue breaths, you're going to do a head tilt chin lift, you're going to pinch the nose, and you're going to get a good seal around the mouth. So you're going to give 2 breaths. If you don't think the first breath went in, don't worry. Just make sure you've got a good head tilt chin lift and pinch the nose and a good seal and try again. If neither of them go in, we're not going to reattempt those. We're going to get straight back on the chest and start CPR again, 30 compressions. And then straight back to your 30 compressions again. So you're going to continue that cycle of 30 compressions to 2 rescue breaths. If an AED arrives, hopefully someone else will be able to open that up for you and start that process. If you've had to get the AED, you would pop that on yourself. I'm going to explain that a little bit more in the next section. Okay, so other reasons you might stop would be if you're physically exhausted and there's nobody else to take over, or if the ambulance arrives and once they have all their equipment ready, they will tell you when they're going to take over. I'm going to take you through the process of using an AED now, which is an automated external defibrillator. So this is crucial to give somebody that's had a cardiac arrest or anybody that's stopped breathing a better chance of survival. So these are really safe pieces of kit, and you'll find them located in lots of public spaces. They have them in telephone boxes, they have them in shopping centres, train stations, and a lot of your workplaces will have these situated in a space that is accessible for anyone to be able to access. Okay, so with your defib, you will have several things that will come with it. So you're likely to have some scissors, a towel or a flannel, a razor, a pocket mask, some gloves, and the pads. Okay. So, before we talk about what we're going to use these for, let's explain a little bit about what the defib actually does. So when we turn this on and the pads are on, it will analyse the casualty's heart rhythm to see if there is a shockable rhythm. What it will then do is deliver a shock if there is a shockable rhythm, which will stop the heart in order for it to hopefully start beating back to its normal rhythm. Now, a shockable rhythm would be if it's in ventricular fibrillation. So basically the heart has stopped pumping blood around the body, but there may still be some quivering, so there's still some movement. If the casualty is flatlining or has a normal heart rhythm, this wouldn't be a shockable rhythm for the AED to be able to deliver a shock. So if when you're doing CPR and you have the AED on, the casualty, and it says no shock advised, that might mean that they're flatlining. So to get them from a flat line to a shockable rhythm into ventricular fibrillation, that's where the CPR process comes in order to try and achieve that. So when the AED comes, turn it on and it will give you some really simple instructions to follow. So it will usually say remove all clothing from patient's chest or make sure that you've called for help, something along those lines. So we'll remove clothing by using the scissors that we have. And that may include the bra as well, if that is in your way of pad placement. If the casualty is wet, so they've come out of water, so the bath, the shower, or a swimming pool or something like that, or perhaps they're in rain and they're very, very wet, then we're going to dry the area where the pads are going to be placed, which is the top right of the chest and side left. So we're going to dry those areas. If the casualty has excessive hair on the areas where the pads are going to go, then we just need to try and take some of that off. It doesn't need to be a clean shave, just try and get as much off as you can. Once that's done, the chest is now ready to have the pads placed on. So I'm just going to show you these. I won't turn the defib on at the moment. I will show you this process in a second, otherwise you won't be able to hear the instructions. Okay, so they come on sticky bits of plastic and you can actually see where the pad is telling you to place itself. So side left, the other one is telling you top right. And that is your correct pad placement. The AED would then recognise that there is now contact with the casualty and move on to the next step of analysing the casualty's heart rhythm. It will tell you to stand clear whilst it's checking for the casualty's heart rhythm. And if there is a shock that needs to be delivered, it will tell you to stand clear again. At that point, we would make sure nobody's touching the patient and it can deliver the shock. It will then say continue CPR if needed. So the only reason we're not going to continue CPR is if this casualty is showing definite signs of life. So we would go straight back onto the chest with our 30 compressions. Back to our 2 breaths and 30 compressions. And we're going to continue that cycle of 30 to 2 for 2 minutes, which is when the defib will stop us again, reanalyse the heart rhythm and go through that same process. Let us know whether there's a shockable rhythm or not, either shock or no shock, and then will tell us to continue CPR if required. So we would go back to 30 compressions and 2 breaths. And we're just going to continue that cycle. If we do have help with us, we're going to start to get a little bit tired, so we can ask them to take over from CPR, ideally after the 30 compressions or after the 2 breaths. Or every 2 minutes would be a natural transition because you're stopping for the defib anyway. So that'll just ensure smooth running of the CPR process and that no treatment is going to be stopped at any point. I'm going to take you through paediatric CPR and the use of AED now. So on a child casualty, unlike the adult, where their issue if they're not breathing normally is probably going to be due to a problem with the heart, with the baby and children, it's more likely to be a respiratory issue. So maybe an asthma attack, perhaps drowning or choking. So they're going to need slightly different treatment than an adult would. You're still going to check for danger as normal. Make sure that you're safe and no further danger is going to come to the child or the baby. You're going to check for response. So, hello, can you hear me? Can you open your eyes? No response. Check now. Head tilt, chin lift. Making sure we don't tilt the head all the way back on the child. And check for breathing for 10 seconds. Okay, I would then let somebody know that I have a child that's not breathing normally and I would ask them to call an ambulance and bring back an AED as soon as they can. I'm going to start CPR. I'm going to start CPR with 5 rescue breaths because they've been deprived of oxygen for a period of time before collapsing, so I need to give them some oxygen. Pinching the nose, good seal around the mouth and lifting the chin. 5 rescue breaths. So now we've got some oxygen in the lungs. We're now going to pump that around the body by doing chest compressions. So we're going to use one hand. Still the placement is the same, right in the centre of the chest, the palm of our hand. I'm going to compress 30 times with the heel of your hand and do 2 rescue breaths. After your 2 rescue breaths, you're going to go back to 30 compressions. So you're going to do 5 initial rescue breaths, followed by 30 compressions to 2 breaths. So then the normal cycle will then continue on as 30 compressions to 2 breaths. Hopefully we will succeed and the casualty will start to wake up. If they don't, you are likely to be advised to use an AED on a child or a baby by your 999 dispatch caller. When you have your AED, the pad placement is slightly different to what an adult would be. Now, a lot of DFibs won't have paediatric pads, and I'll explain what to do if they don't shortly. So, get your paediatric pads out, and again, they will clearly show you where they need to be placed. So one needs to go on the casualty's back, right in the centre of the chest, in the middle of the shoulder blades. The other needs to go on the front, in the centre of the chest. So that is where you're going to position them for a child. Now, a child, for AED purposes, is under 8. If they're 8 or over, then you would use the adult pads in the same way as you would for an adult, so top right and side left. If you have a very small child, or they are under 8, and the pads are starting to get a little bit too close, and almost touching, then you would need to use these pads in the same way as a paediatric. So you would put the adult pads, one on the front, and one on the back in the middle of the shoulder blades, opposite the one to the front. Okay. So, if you have a child that is under 8 and requires the use of an AED and you only have adult pads, this is how you would use those adult pads. If they are 8 and over, then you can use them in the way that is described on the pads themselves, top right, side left. If they're under 8 and you have paediatric pads, then you can use them in the way shown on the pads, so on the front and on the back. For a baby, CPR process. So same reasoning as we just described with the child, they are going to require 5 rescue breaths, but again there's some slight differences when it comes to the CPR process. So you're going to check for danger. When you check for response, you could blow in the casualty's face, clap to try and alert them, give them a little squeeze and a little tickle on the hands and feet. If that doesn't work, we are going to check for breathing. So we're going to open the airway by putting them in the neutral position. So we're not going to tilt the head back because that's going to close the airway off, and we don't want the head too far forward because that's also going to close the airway. So neutral position and check for breathing. So you're just going through your doctor's ABC. Okay, so the casualty is not breathing. I'm going to ask for an ambulance and defib because I've got a baby that's not breathing and I'm going to start CPR. So to do the 5 rescue breaths, I'm going to need to put my mouth around the casualty's mouth and nose because the features are so small, and just little puffs of air. Five rescue breaths. And when it comes to doing the compressions, I'm going to use 2 fingers, centre of the chest, and I'm going to compress 1/3 of the chest depth, which is the same for a child. So about 4 centimetres on a child. 1/3 of the chest depth, 30 times. After your 30 compressions, make sure the baby's in neutral position and give 2 rescue breaths. Then you're going to go back to your 30 compressions and you can continue on with 30 compressions and 2 rescue breaths. If help arrives and the use of the defib is advised, then we can use the pads as we did on the child front and the back. We must make sure all clothing is removed on all casualties when using the defib, where the pads are going to be placed. I'm now going to take you through disorders of respiration. So there are many factors that could cause respiratory disorder. Some of those could be smoke inhalation, asthma, hypoxia and choking, which is one of the main causes and very distressful for the casualty. So I'm going to take you through choking now. If somebody has a mild airway obstruction, they're likely to look quite panicked. They may be able to cough and speak, but that may be difficult. And they may be clutching at their throat to indicate that they're choking. If somebody has a more severe airway obstruction, speaking will be very difficult and probably will not be able to speak at all, and their coughing may become ineffective. They may start to show signs of cyanosis, so blueness at the lips, where there's a lack of oxygen being able to get into the airway and into the lungs. So if you have a mild airway obstruction, all we're going to do is encourage coughing. First, we're going to check that they are choking initially, just to make sure there's nothing else going on. If they confirm that they're choking, just keep encouraging coughing. If that coughing becomes ineffective, we would then take physical action. So I'm going to demonstrate that on my colleague. So you need to stand to the side of your casualty and place your arm across their chest and support on the shoulder. And I'm just going to push him forward slightly. I'm then going to use my hand to do a back blow in the middle of the shoulder blades. Does it come out? No. I'm going to check after each one. Still hasn't come out. So I've done 5 back blows, checking after each one, and it's not been successful. So I'm now going to try something else, which is called abdominal thrusts. So I need to come behind my casualty. I need to find where the belly button is and the bottom of the breastbone and come in between the two. I'm going to make a fist, bring the other hand over. I'm going to lean the casualty over and I'm going to come in and up into the diaphragm in one action. I'm going to check to see if it's come out. I'm going to try again. Nope. It still hasn't come out. We class that as one cycle, so up to 5 back blows and 5 abdominal thrusts is one cycle. At that point, I'm going to ask somebody to call an ambulance and I'm going to repeat the cycle. So I'd come back and deliver up to 5 back blows, checking after each one. If that wasn't successful, back to the abdominal thrust, checking after each one. Now, the casualty is probably not going to last much more than 2 cycles. If they do, then we're just going to continue that process. But the likelihood is they will probably start to fall to the ground. They may get weaker and already be kneeling on the ground. So we can just try and continue that process at floor level. If they do start to fall, we can try and protect their fall, especially their head, but don't take the weight. We don't want to injure ourselves because then that could prevent us from helping them further. But just try and cushion their fall if we can and protect the head. Once they have collapsed to the floor and they're unresponsive, we know that they're not breathing because they've not been able to get any oxygen in, we would just go straight into CPR. So for an adult casualty, that would consist of 30 compressions, followed by 2 rescue breaths. Before you do the 2 rescue breaths, you just need to check inside the mouth to see if anything has come up, and you can remove that with your finger and then continue with the chest compressions. And you'll do the check every time before those 2 rescue breaths. Something else you need to note when dealing with a choking casualty, if you have been successful in achieving getting the object removed from the casualty's airway, then they would still need to go to hospital if you've done abdominal thrusts, just because of any internal damage that we may have done from that force. So make sure that they go to hospital if an ambulance isn't already on its way. We're now going to cover disorders of circulation. The circulatory system is our body's transport system of blood and lymphatic fluids. For the purpose of first aid, we're going to concentrate on the transport of blood throughout the body, known as the cardiovascular system. The heart is a hollow muscular pump about the size of your fist, which sits in the centre of your chest slightly to the left. It has 2 pairs of chambers. One of those chambers will take in oxygen from the air that we breathe in from the lungs, and it will distribute it around the body, giving the tissues of the body the nutrients and the oxygen that we need. It will then travel back to the other chamber of the heart, which will now be deoxygenated blood. That deoxygenated blood will then filter back to the lungs to start that process again. The blood is made up from 4 components. The first is plasma, which is the fluid component of the blood, which is 90% water. You then have your platelets, which act as a blood clotting. You have your red blood cells, which carry oxygen via the haemoglobin, and you have your white blood cells, which manufacture antibodies and protect you from infection. Our blood is made up of plasma, which is the fluid component of the blood, which is made of 90% water, platelets, which help to clot the blood, red blood cells, which carry oxygen via the haemoglobin, and white blood cells that manufacture antibodies and help to fight against infection. The blood vessels in our body are arteries, veins, and capillaries. Arteries carry oxygenated blood from the heart to the body, with the exception of the pulmonary artery, which carries deoxygenated blood from the heart to the lungs. Veins take deoxygenated blood back to the heart. Capillaries are much smaller vessels that form a link between the arteries, veins, and the tissues of the body that allow the transfer of oxygen and nutrients and get rid of any waste product. I'm now going to talk to you about hypovolemic shock, so a failure of the circulatory system. This could be due to low blood pressure, a lack of oxygen in the body, a loss of blood. It could be due to a burn or a spinal injury, or perhaps even poisoning. This is by no means a definitive list, but this is some of the reasons why your body could go into hypovolemic shock. When your body's in hypovolemic shock, it is not receiving enough oxygen around to the tissues of the body. To recognise hypovolemic shock, the signs and symptoms are the casualty would be pale, cold and clammy, where the blood is drawing away from the extremities to protect the vital organs. Their pulse would be rapid but weak. Their breathing would be rapid and shallow. And they may be saying that they feel thirsty and lightheaded. To treat for shock, as we've said, try and treat the cause if you can. Call an ambulance as quickly as possible, as this is a life-threatening condition. If the casualty is conscious, lay them down and raise their legs slightly so they're above the heart. Keep them calm, reassure them, and be ready to start your basic life support. I'm now going to talk to you about fainting. Fainting is a sudden and usually brief loss of responsiveness due to a lack of oxygen in the brain. If somebody is feeling faint, we can aid them to the floor and we can raise their legs in order to get the blood back to the brain. Hopefully they will start to feel better quite quickly. Whilst they are feeling unwell, we can ask them questions to try and find out why they're feeling faint. If it's related to dehydration or lack of sugar, then we can rectify this by giving them some fluid and something sugary to drink. Once they start to feel a little bit better and they can sit up, we might look at giving them something a little bit more substantial to eat. If it's something unrelated to food or them feeling dehydrated, then we may be having to advise them to go and see their GP if they do feel better once they've rested. If somebody has experienced a full faint, we can raise their legs in order to get the blood back to the brain, and hopefully this will improve their condition. If after about 1 to 2 minutes it hasn't improved their condition, then we need to carry out our basic life support. So check in for breathing. If they're not breathing, then we're going to start CPR. If they are breathing, then we can place them in the recovery position. We would then call an ambulance. Bleeding can be classified by the type of blood vessel that is damaged. So that could be an arterial bleed, a bleed from the vein, or the capillary. So I'm just going to explain to you what they might look like as an external bleed. So a bleed from an artery would be spraying out at the same time that the heart is pumping. It would be bright red in colour as it's oxygenated blood. A bleed from the vein would be gushing out or pooling around the casualty, and that would be a darker red in colour as that is a deoxygenated blood. A capillary bleed, this is one of your smaller vessels but can happen on any type of bleed. But let's just imagine that that is just a little cut, perhaps on your finger, will trickle out of the body. I'm now going to tell you how to treat for general bleeding. So when you arrive at the scene, you need to make sure that you have your gloves on and that you've washed your hands. Gain consent from your casualty to be able to treat them, and ask them to apply pressure to the wound and elevate their limb above the heart if possible. When you're ready to examine the wound, expose and examine and see what you're dealing with. See if there's anything in there. If there was to be anything in there, we shouldn't remove anything, because although that's done some damage, by removing a piece of glass or anything that might be stuck in the wound, could obviously open an artery, a vein, and do further damage. So we would leave that in there. If there isn't anything in there, what we want to do is clean the wound. So if we have fresh running water, then ideally we would use that. If we don't, then we can use an antiseptic wipe. We would then look at how to cover the wound to protect it from infection. And that might just be a plaster if it's a small cut, or you may have to use a bandage. If you have a bleed that is starting to seep through that bandage, you can apply a second bandage on top of that one. If it does start to seep through the second bandage, you need to take them both off and start again. Now, we need to think about whether this person needs to go to hospital or not. So it might not be a serious blood loss, but there may be concerns of how they sustained the wound. So it may have been on some metal, rusty metal, or perhaps some dirt or soil. So we might try and find some information if they've had a tetanus jab, and if they're not sure, then they should really go and get themselves checked out. We also need to think about any possible scarring that may be left from the wound. So they may still need to go to hospital to get that glued or stitched to minimise any scarring. So different types of wounds that you might come across could be a laceration, which is a messy tear, perhaps caused by something like barbed wire. You have a puncture wound, so that's a stabbing type wound. A incision, which is a clean cut like with a knife. A velocity wound, so this is impact perhaps from something like a gunshot, and you may also have an exit wound to consider as well. And then you have a contusion, which is basically just bruising. And you have an abrasion, so that's just like a gravel rash. So my casualty here has quite a bad bleed to his arm. I have let him know who I am and that I am a trained first aider, and I've gained consent to treat him. I've asked him to apply pressure to the wound, so if you could just do that and just elevate your arm slightly. Okay. I'm just going to clean the wound for you, and then I'm going to apply a bandage. Are you feeling okay?
Yeah.
Okay. Let me know if you start to feel unwell at all. Okay, take your hand off a second, just going to clean that. Okay, are you okay?
Yeah.
Yeah? Okay, I'm just going to apply a bandage now. I'm going to open the bandage up, pop that on the wound. Okay, if you just want to hold this part of the bandage for me, that's it. Okay, so you want to make sure the bandage is nice and secure and that we cover all of the padded part of the bandage because we don't want the blood to find its way out and we don't want infection to find its way in. So I'm just going to tie this off for you. Does that feel too tight or do you feel okay?
No, that's fine.
That feels okay? All right, and if you just want to pop your hand on your shoulder there to keep that elevated and you can just support that. Does that feel comfortable?
Yeah.
Okay. If my casualty did start to feel faint, lightheaded, then I would lie them to the floor and raise the legs and treat for fainting. If this was a much more serious bleed and there had been a lot of blood loss, my casualty might be suffering from shock. So in that case, I would call an ambulance, lie the casualty to the floor and raise the legs. And if they did go unresponsive, I would carry out my basic life support and be prepared to start CPR. So we spoke about the possibility of a casualty having a foreign body stuck in their wound. So if that is the case, like this gentleman has got a nail stuck in his arm, what we would need to do is pad around that in order to just protect it from any movement and any infection. So I'm going to get myself 3 bandages and I'm going to place them either side of the object. Could you just hold those there for us, please? Thank you. So what I'm doing is I'm making a bridge over the object. So we're not touching it. Not going to cause them any distress. So we're going to get the bandage, we're going to open it up again, and we're going to place it over the wound. You can let go now, thank you, and if you can just hold on to this bit for me. Thank you. So now, you're going to do the same as you did before and cover the bandage. Making sure that you don't knock the bandages into the foreign body. Thank you very much. I'll take that. Just going to tie that off. Okay. So as you can see, we've got coverage of the bandage from all sides. So nothing's going to be able to get in there to infect the wound. And the object is actually in between the 2 bandages in the middle here. So there's no contact, so it's nice and protected. Okay, from here, if it was comfortable, we can rest it and he can protect it and we can allow him to take himself to hospital to get it removed. I'm now going to cover amputations. Amputations is where you have a dismembered body part. If you have to deal with this as a first aider, what you need to think about first is any danger to you or the casualty. So if there is any machinery left on that has caused this amputation, make sure it's switched off. We need to assess the casualty situation. So is there any severe bleeding that we need to apply pressure to, potentially elevate and bandage? If they're feeling dizzy or showing signs of shock, we need to lie them down and raise the legs. And we also need to consider calling an ambulance, especially in the case of any signs of shock. With a dismembered body part, we need to locate that. We need to wrap it in plastic, such as cling film, wrap it in fabric, embed it in ice, so in a bag of ice, with a label on it with the casualty's name on, just so that it doesn't get lost in the hospital. So for an amputation, make sure you treat any bleed as quickly as possible. Keep an eye out for the casualty feeling faint or suffering from signs of shock. Make sure you call an ambulance if there is signs of shock or very heavy bleeding. And be ready to carry out your basic life support. Okay. So just to recap with minor cuts and grazes, we can treat those by simply cleaning them and applying a plaster or a bandage, but we need to make sure if there's any risk of infection or unwanted scarring that they go to hospital. If somebody has any bruising, that can be treated by applying ice and perhaps elevating the area if the area is swollen. If the bruising is still there after 2 weeks, then we should advise the casualty to go and see their GP. I'm now going to take you through somebody having a nosebleed. So if someone has a nosebleed, what we're going to do is we're going to sit the casualty down. We're going to ask them to lean forward with their head, pinch the soft part of the nose, and we can pop something underneath just to catch any blood, so some tissue or a bowl. And And we're going to ask them just to concentrate on breathing out of their mouth. Whilst they're doing this, the blood will start to clot. So after 10 minutes, we're going to ask them to release their fingers from their nose. You'll probably see a clot of blood come out, which is quite normal. If the flow of blood continues beyond this, we would ask them to pinch their nose for a further 10 minutes. After that 10 minutes, we would allow them to let go. The clot of blood will probably come out, and if it continues to flow after that, then we would ask them to pinch for another 10 minutes. We're now getting to 30 minutes. If we get to 30 minutes and that flow of blood is still continuing, we're going to be worrying about the potential amount of pints of blood that they're going to be losing and then going into shock. If they're still okay at this point, we can just make sure that they can get themselves to hospital. If they are feeling unwell, then we may have to call an ambulance. So remember, if someone's having a nosebleed, pinch the nose on the soft part of the nose with the casualty leaning forward for 10 minutes. Check if it's still bleeding, another 10 minutes. Check if it's still bleeding, another 10 minutes, so a maximum of 30. After that point, we would either be calling an ambulance if they felt very unwell, or we would be advising them to go to hospital. I'm now going to take you through seizures. Epilepsy is a medical condition that affects a person's brain. To be diagnosed with epilepsy, it would mean that you would be likely to have reoccurring seizures. The causes of epilepsy could be from being deprived of oxygen at birth, from a brain infection such as meningitis, or perhaps a stroke or a head injury. Although in more than half of the people with epilepsy, they are unable to diagnose the cause of their condition. So I'm now going to take you through two types of epilepsy: tonic-clonic seizures and focal seizures. A tonic-clonic seizure is where somebody goes rigid, falls to the floor, they may let out a cry as they do so, and they will have convulsive involuntary movements. Whilst this is happening, you may see arching of their back, you may see them go quite pale and signs of cyanosis. You may also see frothing at the mouth and maybe some blood that's coming out of the mouth where they may have bitten down on their tongue. For a focal seizure, this may come in the form of an absent seizure, so perhaps where they're just staring into space. They might be wandering around aimlessly. They may be plucking at their clothes or lip smacking. They may be aware, but they may not be aware of their surroundings. So how to treat for both of these? For a tonic-clonic seizure, where they have fallen to the ground and convulsing, we would need to firstly time the seizure, and we'll come back to why the time's important in a moment. We need to make sure the area around them is clear, and that if they are on hard flooring and we're worried about their head banging against the floor, that we pop something to cushion their head. Make sure that's not your hands, because whilst they're in that state, they can be quite strong and they could do you some harm. So just pop a cardigan or a pillow or something underneath the head. Then we're just going to stand back and we're going to allow it to happen. If we aren't aware that this person suffers with epilepsy, then we would need to call an ambulance immediately. If we are aware that this person suffers with epilepsy, then we can allow this to continue for up to 5 minutes. If it gets past 5 minutes, we then need to call an ambulance. If the casualty relaxes and doesn't regain consciousness and has another seizure, we would also need to call an ambulance. Once they finish their seizure, we would then perform basic life support. So we would go in and we would do our primary survey. So we would check that they're responsive, and if they're not, we need to make sure whether they're breathing, and then we would determine whether they're breathing, whether we need to place them in the recovery position or to start CPR. For a focal seizure, we need to make sure that they are safe in their surroundings. So this could happen anywhere. They may be near a road or near some water or near some dangerous machinery. So try and keep them isolated in an area without restraining them. If we can get them sat down, then that's great, but just make sure that they're not wandering off and keep them safe. They may still be aware of what's going on, so we can just calmly talk to them and let them know what's happening. When they come out of their seizure, they may have no recollection of what's happened, so we would need to let them know, plenty of reassurance, and let them rest. The same applies here as with tonic-clonic seizures. So if the seizure goes past 5 minutes, we would need to call an ambulance, and if we're not aware that this person has epilepsy, we would also need to call 999 immediately. There's a few things to remember whilst treating for both of those seizures. The first is to make sure that we don't restrain them in any way, that we don't scare them out of their seizure, that we don't give them anything to eat or drink, and that we don't put anything in their mouth, even if we're concerned that their tongue is compromising their airway. I'm now going to take you through minor burns and scalds. So a burn is caused from dry heat and a scald is from wet heat. So this could be from water, steam, hot surface or fire. We're going to look at 3 different severities of burns. The first is a superficial burn. So if somebody has a superficial burn, that would mean that the top layer of the skin only is affected. So it would be a little bit red, a little bit sore, a little bit tender. You then have your partial thickness burn, where there will be breaking of the skin and there may be some blistering that has occurred. You then have your full thickness burn. This is where all the layers of the skin have been damaged, and that may also be affecting the nerves. And it will look quite charcoaled and have fat, waxy deposits. So to treat for a burn, the general treatment would be to run it under cool running water for a minimum of 20 minutes. After this point, we can reassess the wound and see if it needs further treatment by running it under the water. If we're worried about any risk of infection, we could use clean film to protect it. So we could just pop a couple of layers over the injured area, just scrunch it at the bottom, just to protect it. So clean film is sterile, just rip off that first layer before placing it on the wound. With clean film, it's great because it doesn't stick to the wound, just to itself. You can still see through it, so you can see what the wound is doing, and you can still place it under the water if it needs to go under the water again. You need to think about taking any jewellery off if it's applicable. So if it is on the hand or arm area and there's watches, bracelets or rings, take those off before swelling causes more circulatory issues. So when would you send someone with a burn to hospital? If you have someone that has a superficial burn, usually we can treat that in-house. But if the burn is over 5% of the casualty's body surface, they would then need to go to hospital. 1% is the palm of their hand. For a partial thickness burn, if it covers more than 1% of the body surface, then they would need to go to hospital. For a full thickness burn, we're always going to be advising that they go to hospital, and actually we're probably going to be calling an ambulance for them. Remember, with a burn, with the loss of fluids, there is a large chance on larger burns and severer depths of burns that they would go into shock, so we would need to treat for that also. Some other things to remember when treating a burn is to make sure that you don't remove any clothing, because if you remove clothing that's stuck to the burn, obviously you're going to remove skin as well. You also need to make sure that you don't apply any ointments or creams to the burn. You need to make sure that you don't apply any adhesive or fluffy dressings to the burn also. So when would you send a casualty with a burn to hospital? So you would send them to hospital, as we said, if it is a superficial burn that covers more than 5% of the casualty's body surface. If it's a partial thickness burn that covers over 1%, and for full thicknesses, they would always go to hospital. We would also send them to hospital if the burn went around a limb, if it was on the hands, face, feet or genitals, or if it was a very young, especially under 5 years old, or very elderly. All these people would need to go and get further treatment at hospital. We're now going to cover foreign objects. So for example, if someone has a splinter in their arm and you can reach it with a sterile tweezer, then you can do so. If it is deeply embedded, then we would have to leave it there and tell them to seek further medical attention. If it is something like glass, we would leave that in there as explained in the wounds and bleeding section. If anyone's got anything stuck in their ear or their nose, we're not going to try and remove it just in case we embed it further or cause any further damage. We're going to advise them to go and seek further medical attention. If someone was to swallow something, that might be able to pass through naturally. If they're unsure if that's the case, then they can seek further medical advice or they could call 111. If they have swallowed something like glass or anything else that could be quite harmful to their internal organs, then they would need to seek medical advice and attend the nearest A&E to get themselves checked out.